Okay, why don't we go ahead and get started. I'd like to welcome everyone to Grand Rapids Community College. This is our 5th year doing the Michigan State University Your Health Lecture Series, and we're very happy to do it. Thanks for taking time out of your busy schedules to come this evening. My name is Paul Krieger. I'm professor of biology here at GRCC, and I'm also a proud alumnus of GRJC, and I'm also the coordinator of tonight's event. Our sponsors for this event are MSU College of Human Medicine, GRCC, and Spectrum Health. Let's just take a moment to give them a nice round of applause. At GRCC, we offer an affordable and accessible education to a wide variety of students, whether it's for our transfer students or for students enrolled in one of our degree programs. GRCC is a great place to start your college education. You're sitting in the science auditorium of the Calkins Science Center, which is home to our biological sciences department and our physical sciences department. For more information about our wonderful programs, please see our website at grcc.edu. If you are a GRCC student who needs proof of attendance for this evening's event, you can just sign in on the sign-in sheet, which is located directly outside the auditorium. Now I would like to introduce Mark Breevy, who's the Director of Community and Government Relations at MSU College of Human Medicine, and he'll introduce our speaker for this evening. Mark?
Let's just switch to make sure. Thanks, Paul, and thank you all for coming this evening. We really appreciate this collaboration that we have going on with Grand Rapids Community College and Spectrum Health, and we're really excited to be able to bring Dr. Achtyes to all of you this evening. I'm going to go ahead and introduce Dr. Achtyes. Eric Achtyes, MD, MS, is a staff psychiatrist and researcher holding appointments at Pine Rest Christian Mental Health Services, Cherry Street Health Services, and Network 180, all located here in Grand Rapids. He's currently Associate Professor of Psychiatry and Chair of the Department of Psychiatry West at Michigan State University College of Human Medicine. Dr. Achtyes received his Bachelor of Science degree in chemistry from Calvin College, and I learned tonight that he actually did at least a few classes here at Grand Rapids Community College as well before graduating from Calvin. He also has a Master of Science degree from the University of Washington in Seattle, and his medical degree from the University of Michigan Medical School in Ann Arbor. He then completed a transitional internship in internal medicine at the Michigan State University Kalamazoo Center for Medical Studies, and that was before completing his adult psychiatry residency training at the Massachusetts General Hospital, McLean, and Harvard program in Boston, and that was in 2007. Dr. Achtyes' main research interests include improving treatment for patients with schizophrenia and depression. He has served as an investigator on more than a dozen clinical trials, including several NIMH, NIAAA, and NIDA sponsored studies. He also practices electroconvulsive therapy, ECT, sees patients in local community mental health clinic in Grand Rapids, and serves as the Behavioral Health Medical Director for Network 180, the Community Mental Health Authority for Kent County, and Kent County is home to more than 600,000 Michigan residents. With that, let's welcome Dr. Achtyes.
Thank you, Mark, and thank you for the very warm welcome. It's, of course, great to be here in Grand Rapids. I'm from Grand Rapids originally and love this town, and have been excited to be back here and trying to improve health here in Grand Rapids. I'm going to talk with you tonight a little bit about depression. And depression is something that I think most of us have heard of. We've maybe thought about it, or we know somebody who has suffered from depression. It's an incredibly common and unfortunately can be very debilitating. So what I'm hoping to do is to give you a little bit of a play-by-play. How do I recognize depression, either in myself or in somebody that I might run into, a classmate, a friend, a family member? What do I do about it if I do recognize some of those symptoms? Are there things that I can do that would be helpful? And then, does treatment work? So are there things that are available that can actually help people recover from depression? and lead full and productive lives. Okay, so these are my disclosures. I've done a fair bit of research, again, mostly related to schizophrenia and depression, and then done some consulting work. And some of what I will describe tonight are what are called off-label treatments. So these are things that, some treatments have not been FDA approved, and I'll try to mention that when we talk about those. I also wanted to mention that I will try to save time for questions at the end of the talk. So I'll try to move fairly quickly through so that we can save a few minutes. And I apologize, unfortunately, I have to depart pretty close to 8 o'clock because I have a flight I have to catch tonight. So I'll try to keep things moving along. Okay, so depression. You know, how long have humans been thinking about this and thinking about this problem? And it turns out that Hippocrates, kind of one of the first physicians we think about in the medical field in 400 BC, used the term melancholia to describe any sort of mental illness that he came in contact with. And the Roman physician Celsus in 30 AD described melancholia as being caused by black bile. So this kind of sense that there's something inside someone that is causing them to be dour or to have a low mood. This book, The Anatomy of Melancholy, is the first, by Robert Burton, was the first English text devoted entirely to depression, and you can see that it was written in 1621. And depression in 2017 was declared by the World Health Organization to be the #1 cause of lost years, lost productive and healthy years of any sort of medical condition. So it actually surpassed cardiovascular disease and cardiovascular problems as the #1 cause of lost years of life. Now, these may be people that are familiar to you, many of whom have suffered from depression at one time or another in their life. And certainly, Anthony Bourdain and Kate Spade were recent examples of people who lost their battle with depression. Even though it may have seemed like they were kind of at the pinnacle of their careers or the pinnacle of success, depression can affect anybody. And that's something that I think is important for us to keep in mind. I have a little video clip that I'm going to share with you now. And this is actually a World Health Organization video that was designed to kind of talk to people about what depression could be like or how they might experience it. And they use the analogy of depression being like kind of this dog that pulls you around and bullies you around, as you'll see. And the disclaimer from the group is that they actually love dogs. So we don't mean, for all the dog lovers in the audience, we don't mean for this to be, that dogs are not good, dogs are great. But that was just the way that they chose to depict depression.
I had a black dog. His name was Depression. Whenever the black dog made an appearance, I felt empty and life just seemed to slow down. He could surprise me with a visit for no reason or occasion. The black dog made me look and feel older than my years. When the rest of the world seemed to be enjoying life, I could only see it through the black dog. Activities that usually brought me pleasure suddenly ceased to. He liked to ruin my appetite. He chewed up my memory and my ability to concentrate. Doing anything or going anywhere with the black dog required superhuman strength. At social occasions, he'd sniff out what confidence I had and chase it away. My biggest fear was being found out. I worried that people would judge me. Because of the shame and stigma of the black dog, I was constantly worried that I'd be found out. So I invested vast amounts of energy into covering him up. Keeping up an emotional lie is exhausting. Black Dog could make me think and say negative things. He could make me irritable and difficult to be around. He would take my love and bury my intimacy. He loved nothing more than to wake me up with highly repetitive and negative thinking. he also liked to remind me how exhausted I was going to be the next day. Having a black dog in your life isn't so much about feeling a bit down, sad or blue. At its worst, it's about being devoid of feeling altogether. As I got older, the black dog got bigger and he started hanging around all the time. I'd chase him off with whatever I thought might send him running. But more often than not, he'd come out on top. Going down became easier than getting up again. So I became rather good at self-medication, which never really helped. Eventually, I felt totally isolated from everything and everyone. The black dog had finally succeeded in hijacking my life. When you lose all joy in life, you can begin to question what the point of it is. Thankfully, this was the time that I sought professional help. This was my first step towards recovery and a major turning point in my life. I learned that it doesn't matter who you are, the black dog affects millions and millions of people. It is an equal opportunity mongrel. I also learned that there was no silver bullet or magic pill. Medication can help some, and others might need a different approach altogether. I also learned that being emotionally genuine and authentic to those who are close to you can be an absolute game changer. Most importantly, I learned not to be afraid of the black dog, and I taught him a few new tricks of my own. The more tired and stressed you are, the louder he barks, so it's important to learn how to quiet your mind. It's been clinically proven that regular exercise can be as effective for treating mild to moderate depression as antidepressants, so go for a walk or a run and leave the mutt behind. Keep a mood journal. Getting your thoughts on paper can be cathartic and often insightful. Also keep track of the things that you have to be grateful for. The most important thing to remember is that no matter how bad it gets, if you take the right steps, talk to the right people, black dog days can and will pass. I wouldn't say that I'm grateful for the black dog, but he's been an incredible teacher. He forced me to reevaluate and simplify my life. I learnt that rather than running away from my problems, it's better to embrace them. The black dog may always be part of my life, but he'll never be the beast that he was. We have an understanding. I've learned through knowledge, patience, discipline and humour, the worst black dog can be made to heal. If you're in difficulty, never be afraid to ask for help. There is absolutely no shame in doing so. The only shame is missing out on life.
Okay, so again, one of the questions that I get is quite frequently is, well, how do I know if I have clinical depression or if I'm just having a bad day? You know, that everybody has bad days. We all have ups and downs. Sometimes we have several bad days in a row. How do I know when I've kind of crossed that line between, boy, I've had a bad week and maybe this is taking on a life of its own? That's kind of the question that I start to think about. And you know, we use all sorts of things to, when we talk about depression, sometimes we mean all sorts of different things. It can be a transient feeling of discouragement or disappointment, sadness or grief. But if it really does kind of begin and persist, and the way that we as clinicians think about it is if it's really lasting more than a couple of weeks, that you're really feeling down, having trouble doing things and completing what you used to do, that's when we start to think, okay, maybe this is something a little more. The other thing that I would put is that, you know, for it to you know, for us to kind of think of it as something that needs treatment, it has to cause clinically significant distress or problems functioning. So maybe I'm not working, you know, I'm not doing as well in my job or school, or I'm having trouble taking care of my kids, or you know, those are the kinds of things there really it has to be impacting your life for us to think, okay, maybe this is this might be something more than a bad day. And then what we think about is, okay, well, it might be that you're feeling down because it's depression, but it might be that you're feeling down because of something else. There might be a medical condition, or there might be something else that's going on that we really need to investigate and rule out first before we say, yes, you know, we think this is a depressive condition. Okay, so clinicians, as we kind of think about what constitutes major depressive disorder or clinical depression, these are some of those symptoms, and they talked about it quite a bit in the movie, or in the little clip. So problem sleeping, or diminished interest in things that used to be fun, feelings of guilt or worthlessness, low energy, difficulty concentrating, either eating more or eating less, so appetite disturbance, kind of staying just not moving around, just kind of being so down that you're staying in bed or staying inside all the time and not really engaging in life the way that you used to. And as they said, sometimes questioning whether life is worth living. So when we think about it, we think, boy, if 4 or more of those, along with depressed mood, has been present for 2 or more weeks, then we start to think maybe someone is beginning to cross that line where there's a clinical depression that we really ought to start thinking about treating. We heard a little bit about how it's common. This is something that's present in all cultures all around the world. Estimated lifetime risk is about 16%, a little higher for women than men. Some of that may be what we call a selection bias, in that women are more willing to talk about their problems than men are. Maybe you've experienced that in some circles you've been in. Median age of onset is typically in the 20s, so usually this begins, and it can begin earlier. So, typically 20s, but with mood disorders like depression, it can stretch into the 40s and 50s, and some people have their first bout of depression in their 60s or beyond. So, again, a little bit more common in women than men. It does seem to track in families, so we think that genetics may play a role in the development of these of depression. And then most people have, they may have a depressed period where they're down and then they feel better again. Most people untreated will have another depression later on, and we'll talk a little bit more about that when we talk about treatments. Maybe you're caring for an elderly relative and they're starting to be forgetful or they can't find their way. Sometimes those symptoms that may look like dementia are actually symptoms of depression, having trouble concentrating because they're feeling depressed. So some important things to kind of keep in mind. So what are some risk factors? A family or personal history of depression, family or personal history of alcohol or substance use disorders, having a chronic illness puts someone at risk for developing depression, things like pain or cancer diagnosis, cardiovascular disease, sometimes those can put you at a little bit higher risk for developing depression. Stressful life events, so particularly with that first depressive episode, there can be something that happens, maybe the loss of a job or a spouse. Those can be incredibly important in triggering that first depressive episode. And then adverse childhood experiences, and I think we're just beginning to understand how important these are in terms of putting somebody at risk for depression later in life. But there's actually what we call a dose-response relationship. So the more difficult things that you have happen in your childhood, the more likely you are to develop depression or other problems later on as an adult. So taking care of our kids is really, really critical. I want to present a few general facts about suicide because I think certainly in our public consciousness we think a lot about the links between depression and risk for losing one's life to depression via suicide. So suicide is the 10th leading cause of death in the United States. It's the 3rd leading cause in youth, age 10 to 24. So our young people are really at risk for suicide, and depression is actually one of the leading risk factors for completing suicide. It's actually more than 42,000 deaths per year now in the United States. The rates have unfortunately been increasing a little bit in the last few years, and it's not entirely clear why. 1 out of every 8 to 10 attempts are successful. Generally, men are more often successful than women in terms of losing their life via suicide, and that's typically because men will use more violent or more lethal means, handguns or other guns. The average rate is about 13 per 100,000. Suicide is not just a problem for young people, it's also a problem at the end of life. So as people lose their connections, their family, if people are passing away, friends are lost, there are higher rates of suicide in older populations as well. Okay, so what are some risk factors for suicide? So certain conditions like depression or psychosis can put someone at risk for being a higher risk of suicide. Again, kind of men in their 20s and 30s or over 50, and women kind of around the perimenopausal period is a time of higher risk for women. Substance use puts people at risk, so it disinhibits them. So if someone is abusing alcohol, they're much more likely to do something that they wouldn't do when they're sober. Painkillers are also another incredibly high risk substance. Those who take precautions to avoid rescue, they don't tell anybody before they make an attempt, or who refuse help or feel hopeless, who don't have social supports. Those are the people that are most at risk. Okay, so what can we do about it? You know, how do we respond? You know, how can we be of help to somebody that we notice, or help to ourselves if we're struggling? So who could benefit from maybe seeing a professional? Anyone who complains of depression or suicidal thoughts, or who you know, they may say, well, I'm not feeling suicidal, but they're doing things that would indicate that they're at risk. So maybe they're giving away possessions, or you know, or they've posted things on social media that would indicate that they're really struggling. So my advice to any family members is to take any risk signs like that very seriously, and to do your best to try to help the person. I think the most important thing you can do is listen. So listen, ask them, what are you going through? You know, can I help you? How can I be a friend? How can I assist you? You know, getting them to treatment is really important. You know, maybe if somebody's at risk, maybe you take away the car keys, just like you might for somebody who's been drinking or using substances. Help them get in to see a professional. And it takes a lot of courage to say, you know what, I'm struggling with something and I don't know that I can manage it on my own. It can be very scary to take that first step and ask for help. And sometimes having a friend or having somebody who will go along with you to a first appointment to try to get connected can be a really important first step. If you're really worried about somebody's safety, you know, please, you know, this is an emergency. Call 911. Go to the emergency room. You know, don't let it go. Let's get the person help. The other, I wanted to say one other thing that, just by way of kind of myth busting, a lot of people worry that if they ask if somebody is having thoughts of ending their life, that they may plant the seed of an idea or make it worse. And that's absolutely not true. If you might imagine yourself kind of wrestling with those thoughts and feeling very alone with those thoughts. And if somebody finally asks you about it and asks you how you're feeling or how you're doing, suddenly you're not alone anymore. And that's a really, really powerful thing. Somebody knows how you're feeling, and hopefully together you can go then and find help. Okay, so what help is available? Let's talk about the relief. And again, I'm an adult psychiatrist. I don't treat kids. Everything that I'm going to talk with you about is for the treatment of adults 18 and older with depression. Okay, so meeting with a counselor. Really, really, really helpful first step for most people. If you've got mild or even moderate depression, meeting with a counselor is sometimes the single best thing you can do. It may be all that you need to get through a rough patch or to begin to heal and feel better. And it can seem like a lot because it's, oh, you know, I'm going to go meet with a counselor and then they might want me to come back and meet again. And every time I go, it's a $15 copay. But or whatever, but each of these, invest in yourself. These meetings are incredibly important. Meeting with a counselor or therapist can be life-changing. So I really, I don't know that I can emphasize that enough. Medication therapy can also be helpful. So medication therapy is really first-line treatment if somebody has moderate or severe depression. And if someone has moderate or severe depression, generally we recommend treatment with a medication and meeting with a counselor or therapist, because the two working together do a better job and people feel better more quickly. These are just some of the classes of medications that are available, and I'll talk a little bit about them. I don't want you to get too bogged down in what those are, but we'll talk a little bit about them and some of the evidence for the use of each. So medications for the treatment of depression have been around since the 1950s. And what we have seen as newer medicines have been developed over the years is that we went from kind of broader spectrum treatments to more selective treatments. Some of the newer medicines are, again, a little bit less selective. And then we are constantly looking for new ways to treat depression. So trying to identify new targets. How do we better treat people's depression? And I'll tell you why we're doing that. It's because the treatments that we have currently, they don't get everyone well, and we want to do a better job for people. Okay, so these are some common antidepressants. The selective serotonin reuptake inhibitors, that's kind of the fancy name for them, are SSRIs. What they do is they increase the levels of serotonin in the brain. So there's one hypothesis that some depressions are driven by low serotonin levels, and that if we can increase those levels, that will help people's depression improve. And we have good evidence to support that. All of these medicines have been tested. They've been approved by the Food and Drug Administration and have been shown, compared against placebo, to actually improve depression symptoms. The reason these are often the first-line treatment is that they are quite safe. So the medicines they have some side effects, and we can talk about what those are. Most commonly, upset stomach, sometimes headaches, sexual side effects. But they're very safe. You really can't overdose on these medicines very easily at all, and so they're very safe to take, and they're effective. I think I'll stop there. But if people have questions about these, so Prozac was the first SSRI antidepressant. It was actually synthesized in 1972, but didn't come to be widely available until about 1989. I'm sorry, 1987. SNRIs. So we've been trying to make antidepressants better, and there's, again, evidence that norepinephrine levels may also be low for some people with depression. So these are what we call dual-action antidepressants. They raise both the serotonin and the norepinephrine levels in the brain. And for some people, this is more helpful than just raising the serotonin levels. They also have some indication that they can be helpful for conditions like neuropathic pain. And we know that pain and depression often go hand in hand. If somebody's in a lot of physical pain over a long period of time, oftentimes depression can creep in. Both SSRIs and SNRIs are also helpful for anxiety disorders, and we often see that depression and anxiety travel together like a pack. If you've got one, a lot of times the other one creeps in. Okay, so just a little bit about warnings and cautions with these antidepressants. In young people, so 18 to 24, some people experience a transient increase in actual suicidal thoughts, and some people have thought, well, as individuals start to feel better, they start to think, oh boy, do I want to keep going? Do I want to live? Do I want to live with this? And so suicidal thoughts can actually increase sometimes in younger people taking antidepressants. Interestingly, the suicide rates don't go up. So it's an increase in thinking, but it's something that we want to monitor very closely. So it's important if you're a young person taking these that that you meet with your doctor frequently and talk about any problems you're experiencing. Serotonin syndrome, so this can be if you're taking too much of a medicine that blocks serotonin. Abnormal bleeding, so sometimes individuals who are taking these medicines, we see this if somebody needs a joint replacement, for example. They may need extra blood transfusions while they're getting their procedure. Sometimes people who have bipolar disorder, where you have depression and then you have moods that are too high, sometimes antidepressants can take you back to normal, and then people keep going. They get too much energy. So that can sometimes happen. And then we always ask people that if they're going to stop their medicine, please do it in consultation with your doctor, because there can be discontinuation where if you just cold turkey stop it, you can feel kind of lousy. And then there's some other medical side effects that can happen with these medicines. Okay, so those are medicines that typically affect serotonin levels, but there are other antidepressants that work in other ways. So these are what we call atypical antidepressants, and they have different side effect profiles. They work in slightly different ways. So bupropion or Wellbutrin, for example, doesn't cause the sexual side effects that SSRIs and SNRIs can. So a lot of times for young people, this is throughout adulthood, this is a good choice. Can also help with cessation from smoking. So if someone has depression and they're smoking cigarettes, this is often something that a doctor might choose. Mirtazapine is a little bit sedating. It can help with appetite. So a lot of times we find in elderly patients that are struggling to eat and sleep, this can be a good choice. And trazodone, which was developed as an antidepressant, it can cause you to be very sleepy. So a lot of times we just use it to treat insomnia. So these are, if you remember when some of these medicines were developed, the tricyclic antidepressants are older than SSRIs. And we still use them, but we don't use them as much because the SSRIs are so much safer. Tricyclic antidepressants can be very effective. They have a little bit worse side effects, and they really, if someone were to take too many, they can cause cardiac problems, and sometimes people end up in the hospital because of the cardiac problems. So we want to be we're very cautious about the use of tricyclic antidepressants. It's usually not the first kind of medicine that we use to treat depression. Monoamine oxidase inhibitors, these were the very first antidepressants developed in the 1950s. Again, there's more special care that needs to go if you're going to take a medicine like this. So you actually have to adhere to a particular kind of diet. We call it a tyramine-free diet. But you have to avoid things like aged cheeses, beer, wine if you're going to take this. So for a lot of people, that's a no-go. I'm definitely not going to. It's going to make me more depressed if I can't, eat good cheese. But there are some people where we try everything else and nothing works, and then they try one of these, and it's the thing. It's the thing that works. So again, we have to be very careful, as taking too much of this can be lethal. Okay, so this is this is maybe one of the most important slides that I'll show tonight. And the reason it's important is because I want you to understand this slide really guides, hopefully, what your doctor is doing in treating depression. You can see here we have these different terms: non-response, partial response, response, and remission. And what this means is we want to get your symptoms at least 75% of the way better. We want to get you 75 to 100% back to normal. And that's what we call remission. And if we can get you to remission, and I'll show you a little bit more, you're much less likely to have another period of depression. So this is the goal. Response is good. I mean, if we can reduce your symptoms by 50 to 74%, that's great. We've made a good impact. But your chances of having a recurrence of the depression is higher in these groups than if we can get to here. Okay, so non-remission. So everything except for remission is very common. A lot of times people will have response with some residual symptoms. There's a good chunk that don't really get a response at all. So about a quarter to a third of people don't respond to the treatment that's given. And then there are some individuals who have problems with tolerating the treatment or the medicine that's being given. So we're always aiming for remission. That's what we want to try to target. What are the consequences of non-remission if we can't get there? You're just still not feeling great. So it's hard to function. It's hard to do your job. It's hard to care for your family. It's hard to study. We have that increased risk of recurrence, medical complications. So it's maybe that your medical problem is more difficult to treat, whether it's diabetes or heart disease or other conditions. People who don't remit tend to use the health services more, so they're seeing the doctor for all sorts of things more often. And then there can even be death from other medical problems, suicide. And you can develop what's called treatment resistance, where it becomes harder and harder for us to get you well. So this was one study, and I'm a really kind of a stats nerd. I love this stuff, but I realize most people don't. But I'll try to make this really, really clear. So if we take somebody and we treat them, and they only have a response, so we don't get them all the way better, they are likely to have a relapse of their illness in 68 weeks, so a little over a year. So we got you part of the way better, but not all the way better. Your next depressive episode is about a year away, on average. And again, this is one study. If we can get you all the way to remission, you have got 4 years of solid health. So we really want to try to get people all the way better, if that makes sense. Okay, so I'm going to just share with you again. I'll try not to dive into the details too much, but there was a really big study done by the National Institutes of Mental Health a few years ago. It was done all over the country with all sorts of people. It was called the STAR-D trial. And what they did is they tried to mimic real-life practice. So they said, let's start everybody in this study on an SSRI. If they get better, great. That's perfect. We'll follow them along. If they don't get better, we're going to try some other things. We're going to maybe switch them to another medicine of the same class. We're going to switch them to a different medicine of a different class. We're going to give them therapy, cognitive behavioral therapy. We're going to augment their first medicine with something else. So this is what happens, this is what doctors do, and they wanted to try to study that, what works best. Okay, so in the first part of this study, everybody was given the antidepressant citalopram or Celexa, which is an SSRI antidepressant. It's a good one. So this was a really good place to start. It doesn't interact with a lot of other medicines people might take. It's usually very well tolerated. It's a good, solid antidepressant to start with. So everybody got this. Almost 3,000 people got this medicine when they came in with their depression. And how did they do? Well, about a third remitted. So they got all the way better. And about half had a response. So they got between 50 and 75% better. So we did pretty good with that first trial of an antidepressant, but that leaves 2/3 in this non-remitted category. Remember, we said that was bad. We don't want non-remission. We want people to get all of the way better. Well, the other question I get when I meet with people is, well, how long do I got to take this? How long do I got to take this medicine? And what we found is that in this study, among the remitters, half of them remitted by 6 weeks. So they were taking the medicine faithfully every day for 6 weeks. Half of those people got better in that 6-week time frame. The other half took out to 13 weeks or longer. So, you go in and you see your doctor and they say, you got to take this medicine every day. And you say, but I don't feel better. I'm at week 4 and I still don't feel better. Do I got to keep taking this? I'm at week 6 and I still don't, I'm feeling a little better, but I'm not feeling all the way better. Do I got to keep taking this? And the answer is what I will tell folks is, give me 3 months. Give me 3 months on this medicine. If it's not working at that point, yeah, then we're going to do something. But please, take it every day. It's not something you can just take on days when you don't feel good. You got to take it every day. And then let's see if we can get it. Let's see if we can get to 3 months and see how you're doing. Okay, so what if someone isn't getting better? Let's say we've done 3 months and they're not doing better. So what do? Do we increase the dose? Do we switch it to something else, or do we augment with something else? So keep that first antidepressant and add something else to it. Do we combine it with a second SSRI antidepressant, for example? Do we switch? Do we stop the first antidepressant and do something else? Or do we add other treatments like psychotherapy or bright light therapy? We live in Michigan, right? So we know what the winters are like here. Okay, so in the STAR-D study, level 2 was switching. So if we stop your first medicine and put you on something else, how do you do? And as it turned out, switching worked for about 25% of the people who did it. So another 25% remitted when they switched to a new medicine. And as it turns out, it really didn't matter what they switched to. This is bupropion, this is sertraline, another SSRI, and this is venlafaxine or Effexor, an SNRI. So all of those performed equally when we switched them to something else. Now, and I don't have it on this slide, but when we switched them to cognitive behavioral therapy, meeting with a therapist and going through therapy, 42% of those people remitted. So again, this is why, hammer home, therapy is really, really important. Okay, so what about augmenting? What if we give you something in addition to your first medicine? How does that work? Well, there's a bunch of different things that have been tried in a bunch of different studies. And in the STAR-D study, what we saw is that bupropion, which is Wellbutrin, and buspirone added to that first antidepressant about 30 to 40% remitted with that second, adding that second medicine to the first one. Some of the other things that we have traditionally augmented with, such as T3 and lithium, only about 15 to 25% remitted with augmentation with those medicines. Okay, so what did we learn from STAR-D overall? About a third remitted with the first antidepressant we tried. Another 30% remitted at level 2. And I didn't go through all of the level 3 and level 4, but that was trying tricyclics and monoamine oxidase inhibitors and some of the other things. The overall cumulative remission rate was about 2/3. So by doing these sequential steps, we can get about 2/3 of people fully remitted from their depression. I think that's all I'm going to say about that in the interest of time. Okay, so once I get better, how long should I continue my antidepressant, doctor? That's a common question that I get as well. Do I need to, once I'm better, can I stop it? Should I keep going? What should I do? We typically recommend that once you feel all the way better, you should continue the medicine for another 6 to 12 months if it's your first dip, your first real depression. Give it another 6 to 12 months, and then we can think about tapering off and see how things go. If you've had 2 or 3 episodes or more, your risk of relapse just keeps going up. So once you've had that second dip, then your chance of having a third dip goes up. Once you've had that third dip, your chance of having a fourth dip goes up. So really, by the time people have had 2 or 3 real periods of depression, I'm saying, you know what? Maybe we better find something that you could stay on longer term to try to prevent another dip. We talked about this, avoiding abrupt discontinuation. You can feel just kind of lousy. So again, if you're going to stop your medicine, talk to your doctor, try to taper off of it in a way that won't make you feel yucky. Managing side effects, many of them go away after the first few days. So again, those headache, nauseous feeling, I'll say, if you can give me a couple weeks of taking it every day, usually that gets better, usually goes away over time. But if it's, sometimes the sexual dysfunction doesn't get better, and then we need to talk about it. We need to think about, okay, what else could we be doing? Is there something we could add, or should we switch? There may be some behavioral modifications, exercising, avoiding caffeine. Maybe we need to, if your medicine is making you tired, maybe we give it at night or divide the doses. So there's lots of things that we can do to manage side effects, and it's important to work with your doctor to figure that out. So which one, well, doctor, which one is the best one for me? You know, that's what everybody wants to know. You know, which antidepressant works for me? I'm the one that needs to get better here. You know? And unfortunately, the best antidepressant is the one that works for you. And I don't always know which one that is when we start out. Sometimes what works for a family member may also work for you. So if you've got a brother or sister, or you've got a parent, or you've got a child who has been treated with a particular medicine, and after trying several things, they landed on sertraline, and that one worked really well, there's a chance that that might be a good one to start with for you. We really, we can't prove that one SSRI is more efficacious than the other. They're all about equally efficacious. And then I often get asked this question: what about generic medicines and brand name? And the way that I respond to that is, by law and by testing, generics are the equivalent molecule to what's in a brand name medicine. What might differ a little bit is the colorants or binders or other things that hold the pill together, but they need to be equivalent in order for the FDA to approve them to be used as a generic medicine. So that's my standard line on that. I have people who disagree with me vehemently, but so depressive breakthrough. Oh my goodness, I'm so glad, I'm feeling better, and now it's a couple years later and it's coming back. What's happening? And we sometimes see that for whatever reason, the treatment that's been keeping somebody well and functioning just kind of starts to peter out a little bit. It's just not quite working the way that it used to. So we get these depressive breakthrough symptoms, and sometimes they're precipitated by something, stress or substance use, or maybe they started a new medicine, and for whatever reason, it's interacting with the antidepressant in a way that makes it not work quite as well. Or maybe there's a new medical problem that's contributing to some of the symptoms. Or maybe we didn't quite get the diagnosis right and we thought it was just depression, but maybe there's a part of it that's bipolar and we missed it. So my advice is not to stop your medicine at that point, but to call your doctor, go in, talk about it, see if you can figure it out together. Okay, so if treatment isn't working at all, one of the things that oftentimes happens when I talk to people is they just really haven't been taking it every day, or they have been taking too low of a dose. So a lot of times we can address that by figuring out, is it a side effect that's causing a problem, or is it too hard to remember? Are you forgetting? So that can be a component. A lot of times there are other comorbidities, other illnesses, drug interactions. Maybe we got the diagnosis wrong. Those are some of the things that we'll look for. I talked a little bit about psychotherapy. So these are all evidence-based kinds of psychotherapies for the treatment of depression. Cognitive behavioral therapy many people have heard of that. It's typically a time-limited therapy, so 12 to 20 sessions. Some of the other therapies are a little bit more long-term, and which one is right for you may vary. Typically, cognitive behavioral therapy helps people get their symptoms under control a little bit more quickly, but more of a psychodynamic type of psychotherapy may allow you to dig in a little bit deeper on some other things. Adding therapy after successful treatment can be very helpful. So when people here, this is what's called a survival curve, meaning these people are still well. So people who added cognitive behavioral therapy after they got well stayed well longer. This is months. So if you look at this is 6 years. So if I do cognitive therapy, I'm likely to stay well much longer than if I just took a medicine, got well, and then I don't do any therapy. I'm much more likely to get depressed again. And then this also shows that this is kind of the opposite way of looking at that same curve, but people who had medications and CBT stayed well longer than people who got medications and clinical management. Okay, so if those usual treatments, medications and therapy don't work, are there other things we can do? And the answer is yes. Electroconvulsive therapy, or ECT, is the most rapid and effective treatment for major depression. Works in 60 to 90% of cases. Was developed in the 1930s, FDA approved 1979. It's usually 6 to 12 treatments being given 2 or 3 times a week. It's more of an involved process. I mean, you come into the clinic, you have general anesthesia. The treatment only lasts about 10 minutes, and then you wake up. It takes about 20 minutes to wake up from the anesthesia, and you go home. But it means that you probably can't work that day. You probably can't, be driving yourself. You need to have somebody helping you. So it's a little bit more invasive of a treatment. And then usually we recommend that people maintain medications while they're getting ECT. And the reason for that is because once ECT gets you well, we want to keep you well. And sometimes people can stay well with medications, and sometimes they need to come in for booster treatments of ECT in order to stay well. Other therapies, TMS, or transcranial magnetic stimulation, is a treatment that has been gaining a lot of traction lately for the treatment of depression. The nice thing about it is that you don't have general anesthesia, so you can come in the morning, you can get your TMS treatment, and then you can go to work. It's about 30 to 45 minutes, but it's every day for 4 to 6 weeks. So it's a commitment to come in before work or before school, after school, and get the treatment done. And it's about, the effectiveness is about the same as another antidepressant trial, so about a half respond and about a third remit. But you can think about, let's say in someone who's pregnant or expecting, this might be a great treatment because then they're not getting a medicine that goes to the growing baby, and it allows them to get well. Vagal nerve stimulation, I won't say a lot about this. It was FDA approved for treatment-resistant depression in 2005. Results have been mixed. Deep brain stimulation, very successful to treat tremor and obsessive-compulsive disorder. It's still investigational in terms of the treatment-resistant depression, and all of the studies have very small numbers of patients. Some other avenues for treatment of depression. So ketamine, this is one of these new targets that we're looking at. It works on a receptor in the brain called the NMDA receptor. It's rapidly acting, has anti-suicidal effects. The biggest question right now with ketamine is the duration of benefit. So somebody gets this medication, they might feel better for a week or maybe 2 weeks. But the next time they get it, maybe it's a week to 10 days. The next time they get it, maybe it's 4 or 5 days. So how do we best use this medicine? I don't know that we have those answers yet. Bright light therapy definitely works. So that you can get full spectrum light through, there's a company called Northern Lights where you can order special full spectrum bulbs, especially for seasonal affective symptoms. Living in Michigan in the winter can be very helpful. St. John's wort can be helpful as well. It's actually a serotonergic treatment, so you want to be careful about mixing it with SSRIs, SAMe and methylfolate, omega-3 fatty acids, vitamin D, all things that people are looking at in terms of other treatments. And then, of course, exercise, which was mentioned in the video. Okay, so in conclusion, be prepared to recognize symptoms of depression, get treatment when you encounter it, encourage others to get treatment. Don't necessarily assume it's an appropriate reaction to a stressful situation, particularly if it's hanging on and kind of taking on a life of its own and impacting functioning. If it's lasting more than a couple weeks, it's, go get help. There's good help available. And this is probably the most important one, is don't give up. See a mental health specialist if you need to. Get a buddy to go with you. The thing that I say about therapy, so if you're seeing a therapist that just doesn't seem like the right fit, don't give up on it. Go find another therapist. One of the most important things in terms of whether therapy is effective is whether you feel a connection to your therapist and if you feel like that person can help you. So it's your health that you're talking about, so persist until you get the treatment that's helpful. And with that, I'll stop, and we have a few minutes for questions. Yeah.
Do you think that you would prescribe medicine before you try to treat with a daily diet?
So that the question, everybody heard the question, okay? Okay. So the question is like, how might diet impact things? I think what I would do is I would want to assess how somebody's doing. So is this a normal response to a stressful situation? Is this something that is really taken on a life of its own? And if it's kind of taking on a life of its own, if it's really the symptoms are moderate to severe, we may make some dietary changes to help somebody feel better. But at that point, I would prescribe a medicine too, because that's what the evidence suggests we should do, is to treat that aggressively. But there's no question that what we eat and how we eat can impact how we feel. And having a healthy diet is an incredibly important part of that, along with exercising.
Thank you for your presentation. So my question was going to be based on, because I'm from California. I'm here for medical school. But I'm Cambodian American. So my family, we had a history of a genocide that killed 2 million people. That's almost like 1/4 of the population itself. So there was a refugee population that came to Stockton, like 16,000, that are residing in Stockton, California itself. 65% of the refugee population that came had some sort of trauma or some type of mental illness. And the key difficulty is that I hear this a lot too. Even though my generation never experienced war, even though we are experiencing some type of war growing up in these areas, but not in the sense of the genocide, but we are at more of a risk for these type of mental disorders such as anxiety, PTSD, and et cetera. Can you tell me a little more about the epigenetics about it? The research of what's going on, why that is?
Yeah. There's no question that being a refugee or transferring, moving to a new country or a new culture is a risk factor. And it's not just a risk factor for depression, it's actually a risk factor for psychotic disorders, other mental health disorders. And it really seems to be tied to that trauma that you're talking about. And some of it seems to be intergenerational. So even if you didn't directly experience the traumatic, the genocide yourself, your parents, your grandparents who were alive and who are part of that, when you move, some of that comes with you. I don't know. Epigenetics is important. So for those who aren't familiar with that term, what that is how environment impacts the way genes are turned on and off at different times in someone's development and life cycle. And epigenetics can be impacted by the environment. And genes, of course, then impact how we function. So what I'll say is we know that those are really important. I am not an epigeneticist, so I don't want to misspeak and say that I know all of the impacts that epigenetics has, for example, on major depressive disorder. We definitely know from the work with ACEs, adverse childhood experiences, that the more environmental stressors someone has growing up, it's got to change the way genes are expressed and how they function. And there does seem to be some people are studying this, intergenerational, how does that pass from the person who is directly part of the trauma to their kids? Is that an epigenetic phenomenon? Is that a learned behavior phenomenon? I see my family member being anxious, and then somehow that becomes part of my character and how I interact with the world. So that's a really important area for us to continue to investigate and understand better. Yeah.
Maybe time for one more so you don't miss your flight.
Sure, okay.
So to go along with what Sonny said, so here in West Michigan, what options are available for families who are immigrants or refugees with mental illness, especially with the language barrier?
Yeah.
It would be quite challenging to address somebody in psychiatrist when you have the language barrier.
Yeah, so any of our area hospitals should be able to provide language translation services. I'm most familiar with, say, Network 180 and Cherry Health in Pine Rest, and I know that we have language translation services available. That's not always enough, I mean, to provide really culturally competent care. And I think because this community has been more homogeneous than some others for a long time, we've got a little bit farther to go to get caught up in terms of providing really culturally competent care. But we need people like yourselves who are training here to stay here and help us provide more culturally competent care. I think that's really important.
All right. Well, thank you, Dr. Achtyes. Let's give him one more.